needs and issues that has been portrayed about increasing healthcare costs. And that is something that we disagree, that it cannot be rushed. The examples of successful DRG has been enumerated in the public healthcare. And I didn't get the date year correctly in the presentation. Was it 2003 or 2013 when you first started? If it's 2003, then I'm worried. It took 23 years and still nothing has come up in a conclusive way. But if it's 2013, then it's not too bad. Then it took about 10 years to implement and pilot it in a public hospital. Important aspect here is that if it's going to be made sustainable and useful, private healthcare cost is a little bit different than using public health financing. Here is what we're talking about, a taxpayer's budget that the public healthcare gets. In private healthcare is a little bit different. The complexity of private healthcare costs is very different. So a lot of work that we need to do together. Partnership in DRG and a sustainable solution for private healthcare is key. It is important for us to sit together, and it cannot be done in 1 year or 2 years. It will take more than that. So that's important. And we must also remember, like what Tan Sri had mentioned, and I wanted to say it, but Tan Sri being much older and senior to me, he is much faster in this and still very sharp. Public healthcare has got public healthcare services. You are responsible to the taxpayers' money. But when private healthcare is concerned, especially private hospital, we are responsible to the investors' money. And also some of them have bought public shares. Public have bought shares in the stock market in the private healthcare. So we are responsible equally like what the public healthcare is. So we cannot experiment a system without its solid, being solid in its merits before we implement a DRG in the private healthcare. We are very interested, what Prof. Aljudin said, that DRG has shown some success in a private setting in Indonesia. We need to actually study the concept to make private healthcare more efficient. The public-private partnership through Protect Health was cited just now, saying that there was one method of using DRG. But I must say that DRG that was used, or the concept of DRG, was not very successful because private hospitals actually incurred losses in that public-private partnership. We have data to show now over the period of the last 1 year, there are actually losses that the private hospitals are actually absorbing it. They're doing it at a CSR, and I am happy to share the data on the losses that we actually make in the PPP. But we are willing to do. Private hospitals are actually willing to do to help the government in that sense. So if you were to say that was the DRG concept, that wasn't the correct concept, the calculation was actually not exactly correct in that sense. And lastly, Dr. Sri and the panel, we wish that DRG, like what Tan Sri mentioned many times, that DRG is a tool. This tool shouldn't be now added into the ACTA 586 because that is not the tool that you should put into the ACTA. That's what we were told, that we might be incorporated into the Act. I think that shouldn't be incorporated into the Act. It's a tool for us to make public-private healthcare delivery system more efficient, but not by mandating in law. I mean, that's our view that it shouldn't be done in that manner. We are happy to work together and come out with a very sustainable solution with DRG. Thank you.
Thank you.